My name is Elena Janjigian. I'm a medical oncologist on the GI service, and I'm very excited to have you here today. And the focus of our 43rd annual alumni meeting this year is esophageal and gastric cancer. We have international speakers coming from US, Japan, Europe, and most excitingly, we have, in addition to clinician and experts in gastric cancer, we have scientists coming from SKI and others centers to give us perspective on the future of multimodality therapy and how we can improve outcomes for our patients by incorporating hypothesis-driven scientific research and rationally designed clinical trials. So in gastric cancer, there's a lot of genomics and germline genetics that incorporate into therapy and decision making for our patients. And I'm excited to have the first set of speakers looking at applying genetic testing in esophagogastric cancer. Dr. Laura Tang needs no introduction. She is our guru and maven in gastric cancer pathology, known worldwide for her intuitive approach to this disease, and she's taught many of us key pearls about this heterogeneous and often difficult to diagnose cancer. And then we have Sophia Stadler, my personal go-to person for any, and for I think most of the institution, for any germline-associated questions in GI malignancies. And of course, Vivian Strong will give us an overview of our approach in risk-reducing surgery in patients with germline predisposition syndromes and gastric cancer. With that, I'd love to introduce Dr. Tang, please.
Thank you. Thank you, Elena, and good morning, everyone. And I appreciate the opportunity to speak at the opening of this exciting day. Pathologists usually get to speak the last, so I like this meeting already. So I was giving the title of Pathogenesis of Evolution of the Disease. And let's just review what's happening in the past 10 years. It seems like the gastric cancer as well as esophageal cancer has moved down from the top list. But when you look at the absolute numbers, there's not much change, both in developing countries and developed countries. Similar features in female patients as well. So globally, esophageal cancer remains number 8 most common cancer worldwide, and number 6 most common cause of death. As you can imagine, that more than 80% patients will die from this disease. Interestingly, the incidence is higher in men, and in particularly in Asian men, and also African women. So we don't know whether this is related to the environmental and genetic factors. Looking at the gastric cancer, it remains number 5 most common cancer and the 3rd leading cause of death worldwide. And as we know, most of these cases are in Asia, particularly in China. And as we can see here, the difference in modality is higher in Asia and the lowest in this region, North America. This is probably due to the early detection, early stage of cancer in North America. So just put things in perspective, this particular year, we are going to have 26,000 cancer new cases, and 10,000 of them will be dead. And more morbidly for esophageal cancer, 17,000 new cases, and most of the patients will die from the disease. So just to look at an overview, 5-year survival in the past few decades. And as you can see, for both esophageal and gastric cancer, there's a big jump from 80s to 90s and current. So this is probably the combination of early detection for both diseases, as well as H. pylori eradication in gastric cancer, and then perhaps standard and targeted therapy for esophageal cancer as well. So from etiology and pathogenesis, we know the environmental factors are important. Alcohol, tobacco, perhaps spicy food, and greasy food, which can cause reflux. We also know that there's infectious etiology, which are most important in certain areas of the world. Both H. pylori and EBV virus are associated with gastric cancer. Also genetic inherited disease, you'll hear more later during the day. So we also learn from an anatomic location of the disease, the proximal, esophageal, and cardiac type of cancer are mostly related to reflux, and distal stomach, particularly in the antrum, in Asia, are related to H. pylori associated gastritis and intestinal metaplasia and atrophy of the mucosa. The diffuse type cancer mostly occur in the body of the stomach, and we know very little about that. So in terms of pathogenesis for squamous cell carcinoma worldwide, 1/3 of the cases are in Asia, particularly China and Japan. While tobacco use and alcohol consumption are major factors, we also know that there is autosomal recessive inheritance, as well as certain genotype susceptibility in several segregates of esophageal cancer in central part of China. Speaking of the adenocarcinoma arising from GE junction, this started with Mr. Barrett's, Norman Barrett's. He correctly identified the disease. These are his initial drawings. However, that his name is associated with enormous confusion in the past few decades. So there was alarming rates of esophageal adenocarcinoma in white male, particularly in Scandinavia in 90s. As you can see, the gastric cancer is coming down, and esophageal cancer is going up. In this period, it's very sharply raising incidence. The good news is this has been stabilized over the past few years. So the early assessment of esophageal cancer in association with Barrett's, I believe, was overestimated due to limited number of cases as well as the bias of the studies. This is a little bit more recent study assessing over 1,000 esophageal cancer, Barrett esophagus, and its progression to low-grade dysplasia, high-grade dysplasia, early carcinoma, and frankly, cancer. So as you can see, the incidence is much lower than the previously assessed. And in addition, it takes quite a long time for Barrett's esophagus to progress to cancer. So in terms of reflux associated with Barrett's esophagus and cancer, there's a huge pH gradient, so you can imagine during the swallowing, there's this type of mucosa is subjected to pretty strong chemical insult. Pathologically, it started off with squamous columnar junction mucosa with chronic inflammation, followed by intestinal metaplasia, glandular dysplasia, and cancer. Here's an example of Barrett's esophagus associated with a cancer right at the G junction. And the etiology is similar in the stomach, except in this situation is H. pylori infection in the distal stomach, started with active inflammation, intestinal metaplasia, glandular dysplasia, as well as intestinal type carcinoma. So the good news is, as the discovery of H. pylori, one can see that the intestinal type cancer is going down, although the diffuse type has little change. So for that, we owe the gratitude of Barry Marshall and Robin Warren for not only discovered the H. pylori as a pathogenic bacteria, also carcinogenesis for gastric cancer. So we also learned a great deal of these diseases from surgery, most famously Bill Rath. And this is glorious moment performing these operations, and these are the specimens preserved. However, we now know that patients underwent this type of surgery for a non-neoplastic disease, particularly gastric and duodenal ulcer, can develop so-called remnant gastric cancer, usually present at the site of anastomosis on the side of the gastric mucosa. So clearly this is directly related to bile reflux. So we also learned that pathohistologically, we can classify the tumor as intestinal type and signaling cell carcinoma. And they have a specific clinical phenotype as well. Intestinal type cancer usually occur in older patients with a lower socioeconomic situation, oftentimes H. pylori associated in the distal stomach, and most of the time is moderately differentiated, but they can progress to mixed phenotype. The diffuse signaling cell type usually occurs in younger patients, higher socioeconomic situation, no association with the surface mucosa atrophy and dysplasia, and occurs in the body, and they are inevitably poorly differentiated. So clinically, from prognostic point of view, we know diffuse type in red is doing worse than the intestinal type. In addition, they have very sharp mRNA phenotype. Here's the blue for intestinal, red for signaling ring cell. And most importantly, they appear to have a different sensitivity for chemotherapy, with intestinal type in blue are relatively more sensitive to 5-FU, oxaliplatin, and diffuse type appears to be more sensitive in cisplatin-based therapy. So speaking of pure diffuse type, which is very rare, excuse me, we know there's a familial type, which is a germline CDH1 related situation. And also there's a sporadic one. So I say sporadic because we don't know for sure the precise etiology of this phenotype. So for the diffuse type cancer, it usually involves the entire stomach. Here's an example of Lenitis plastica. The mucosa is markedly thickened. However, there's no mass lesion on the surface, no mass, no ulcer. This is a whole mount of H&E slide, again showing the intact surface mucosa and thickened gastric wall. And you can only appreciate the infiltrating carcinoma by an immunohistochemical stain of cytokeratin, all the way from submucosa to serosa. So we know that E-Cadherin germline mutation was initially discovered in New Zealand by Guilford, with the documentation of one allele mutation in 3 Morris families. We now know function mutations of have been detected in more families with different ethnic backgrounds. So again, the mucosa in this kind of setting is pristine. There's no inflammation, no metaplasia, no dysplasia, but you have abnormality right at the junction of foveolar and ocentic mucosa. As higher power of view, you can appreciate these signaling cells. We also know that hereditary conditions other than CDH1 are associated with gastric cancer. Here are just a few examples. Lynch associated with gastric cancer with many intraepithelial lymphocyte infiltration, FAP, familial adenomatous polyposis, not only susceptible for colon cancer, but also can develop gastric cancer less commonly, as well as Peutz-Jeghers syndrome. Speaking of a genetic association, we know famous people always also get cancer. Here is Pope John the 23rd and Napoleon. They both have a strong family history of gastric cancer. So a few years ago, I visited the beautiful island where Napoleon was born, and this was his bed, trying to get some hair or something for DNA, but unsuccessfully. Instead, I found this pathology report for his gastric cancer. It turns out that his cancer was located in the distal stomach and was thought to be H. pylori associated instead of a genetic inherited. And they even have the stage T3 and 1M0. So what about this family? So they actually, their house has their own well. Everybody's taking the water from the same source. So also I discovered later that it turns out that Corsica has the highest incidence of H. pylori infection in Europe. So the family, everybody's drinking water from the same well, and we believe that his father, his uncle, 2 of his 4 brothers, and 1 of his many sisters died from cancer. It's probably the similar etiology. So we asked the question, why gastric esophageal cancer have poor response to therapy in most cases, and there has been no dominant target or targets identified for each disease. So from pathological point of view, I think this is a very dynamic process. It takes a long time to develop cancer from the mucosal pathology. And even when the cancer is developed, they can interchange phenotype from intestinal type to signal ring cell diffuse type and the pure signal ring without the mucin. And all of these can be interchangeable. So you can imagine, along with the phenotype change, there's probably genomic accumulation as well. So just to simplify the 2 possible models, so I have the top-down, which is the intestinal type started from the lumen on the surface due to exposure to carcinogenic agents. And then there's a bottom-down, which is the diffuse type. It doesn't really have the surface component. The cancer started from lower down here. So from the top down, it's very complicated. As described again, there is a long pathological process from normal epithelium all the way to cancer. Along with that, one may start with a few genomic events and with accumulating abnormalities, so it is really difficult to identify the driver when the cancer is advanced. However, so-called the bottom-down model is probably simpler, but we don't understand completely. The only thing we know is the CDH1 associated with cancer, and the sporadic one is probably a simple hit, but we haven't discovered that yet. So you'll be seeing this chart again. We know now the gastric cancer is classified by 4 different subtypes. Chromosomal unstable, genomic stable, mismatch, and EBV. Unfortunately, majority of the cancers for gastric esophageal cancers are so-called genomic unstable and genomic stable. These are less targetable. Only about a quarter of these have therapeutic indications for now. And esophageal cancer, as you can see, the squamous carcinoma has a completely different genotype with the rest of adenocarcinoma. And the G-junction adenocarcinoma shares the chromosomal unstable genotype with the rest of the stomach, but now the EBV subtype. So, in summary, I think the landscape of knowledge over the decades from epidemiology, demographics, and the pathology indicates that disease is indeed heterogeneous. And we need to reclassify the diseases using evolving pathogenic and genomic mechanisms. And delineation of molecular mechanisms is necessary to define the prognosis and therapy. And optimizing management and outcome requires early detection of a neoplastic phenotype, and finally, ideal management strategy requires multidisciplinary indication. So in closing, let me put the topic in perspective. Both esophageal and gastric cancer remain grim disease. And advances in management started with radiology, followed by endoscopy and eradication of H. pylori. And in terms of therapy, it was initiated with surgery, which was extremely effective, followed by medically and development of targeted therapy. And it is clear that the future advances depends on further genomic classification of the disease, and you will hear more throughout the day, and also efficacy of multidisciplinary management. So it was my pleasure to open this wonderful day, and thank you for your attention.